Hello all, and thank you so much, Brianna, for the introduction. Thank you for everyone who included where they're joining from on the chat. We really appreciate it. It's wonderful to see so many partners and also new names, and very exciting to have you all with us today. My name is Halitz Villegas, and I manage the Forced Marriage Initiative. And I am joined today by my colleague, Casey Carter-Sweckman, who is our Director of Public Policy. And together we will facilitate the webinar. I'm very excited to have a webinar focused on healthcare providers because you truly are a link for safety for survivors of forced marriage. Before we dive into the material, we'd like to thank the United States Department of Health and Human Services Administration for Children and Families Office on Trafficking in Persons for funding this webinar. This webinar has live ASL and Spanish language interpretation. To listen to this webinar in Spanish, please select the globe icon on the bottom of your screen and click on Spanish language, and that should take you to the Spanish audio. We would like to thank Dr. Neha Batool, whose research on the mental health impacts of forced marriage will be discussed throughout this webinar. Dr. Neha Batool could not be with us today, but she did provide permission for us to share her direct information, which is located on the screen. That's the information to her practice as well as her direct email. And if anyone needs further support in connecting directly with Dr. Batool, we can certainly facilitate that. Or if you have additional questions that require her expertise, again, we can certainly facilitate that connection. And now I will pass it to our Director of Public Policy to share more about our organization. Casey.
Thank you so much, Halitz, and thank you everyone for being here today. Really appreciate it. I'm also super passionate about the role that healthcare providers can play in creating a safety net for survivors of gender-based violence. So very grateful to everyone who made time to be here today. Just a brief overview of the Tahirih Justice Center. Like Halitz said, I am the Director of Public Policy. I've been with Tahirih a little over 10 years, and the Tahirih Justice Center has been around since 1997. We're a national nonprofit organization serving immigrant survivors who are fleeing gender-based violence. Our interdisciplinary trauma-informed model of service combines free legal services and social services with advocacy, training, and education. We partner with law firms across the country to deepen and expand our services through our unique pro bono model, and by amplifying survivors' experiences in communities, courts, and Congress. Our mission is to create a world in which all people share equal rights and live in safety and with dignity. So the Forced Marriage Initiative, or the FMI, which you might hear us say throughout the presentation today, is a project of the Tahirih Justice Center. Tahirih does have offices providing direct services throughout the country in Maryland, Virginia, Georgia, Texas, and California. We provide immigrant survivors of gender-based violence with immigration legal services for free, along with social services. And the Forced Marriage Initiative is a national program. So we are serving survivors and individuals at risk of forced marriage in those 5 states that I just mentioned, but also in every other state in the US. And we're serving individuals with US ties who may be taken overseas for forced marriage. We also have a robust policy team and other programs to meet the specialized needs of different groups, including our Afghan Asylum Project. So we do have a lot to cover today, but we are going to do our best to leave time for breaks and to answer questions. Our agenda for today is to introduce Tahirih and the terms that we are using when we're talking about these issues, talk about why forced marriage is happening in the United States, talk about the intersection of forced marriage, human trafficking, and other forms of violence. We're going to unpack a case scenario, a narrative, and we will discuss it together and problem solve together. We will unpack the issue of child marriage in the United States. And last but certainly not least, we will go over practical tips for responding and creating opportunities to provide support to survivors within your practice. By attending today's webinar, you will receive a foundational understanding of the issues of forced and child marriage as they are happening in the U.S. You will learn to recognize the way in which forced marriage and child marriage can intersect with human trafficking, sexual assault, child abuse, stalking, female genital mutilation or cutting, and domestic violence. We will also help folks to identify potential warning signs and indicators that someone might be at risk of forced or child marriage, and provide tips for how to respond appropriately. And right now, our colleague Bree is going to launch a poll just to take a baseline measurement of where folks are at on this issue.
And so the poll question reads, have you ever worked with a patient who was facing forced marriage dynamics? The selections are unsure, yes, or no.
Thank you, Halitz. And yes, okay, now everyone who is with us has answered. And Bree, if you want to end the poll and show results. We have a pretty even split this time. This is actually the first time I've seen something like this, with 38% of folks saying they're unsure, which is fairly common. There's usually about a quarter to 50% of people at the beginning of a training will not be totally certain whether or not they've worked with someone who might have been facing forced or child marriage. Then we have 32% of folks saying yes, they're absolutely sure that they have, and 32% saying no, they haven't. So a very interesting split on the poll.
Thank you, Casey, for that. And thank you, Bree, for sharing the poll and everyone who participated. As I mentioned earlier, we're very excited to have this healthcare focused webinar. Often when we are providing training or at educational events, we are fortunate to have many victim advocates present or hotline advocates present, shelter case managers. But often we are not interacting with many individuals who are healthcare providers, which we see as a huge training gap, as many of the clients we have worked with have named going to medical appointments and have named that those appointments may have been a potential avenue for help seeking, potential avenues for a positive interaction with someone outside of the family or outside of the community who perhaps could have led them to supportive services. For many, these appointments happen before the marriages took place, which again makes medical providers key in preventing forced marriage. And for others, the appointments were made after the marriages may have taken place, but still they were undergoing many or multiple forms of gender-based violence, which makes, again, these appointments and the interactions with healthcare providers incredibly important in the potential help-seeking process and just the healing journey altogether. And so to ground us in the importance of being here, I would like to share participants' narrative from Dr. Batool's research on the mental health impacts of forced marriage. And one of the participants was quoted to say that they realized the hearts they had for their patients and how much they truly cared. It's also the first time that my voice was valid. That visit was the first time that somebody shook my reality and made me realize there are people on the outside world that are not evil. I think this quote truly grounds us in what we believe, and it is also incredibly powerful to hear directly from someone who survived a forced marriage and who participated in Dr. Batool's research. And so Casely named a bit about our program earlier, and I shared in my introduction that I manage the Forced Marriage Initiative. And just a bit about who we are. We are a national program that was created in 2011, really to spark a national response to the issue of forced marriage right here in the United States. Forced marriage is a global problem, and the United States is part of that globe, and we have this form of violence right here. And so what we learned in 2011 from research, from a national survey, from the calls we were getting from service providers and individuals at risk, is that this issue was not necessarily coming to the light to service providers. Folks did not know how to respond. And so we launched our program and uniquely launched our program to serve individuals who are not necessarily needing immigration legal aid. As Casey mentioned, Tahirih focuses on immigration legal expertise, but folks were calling us who did not need this type of help. And I think learning about this the intro of our program, how we came to be, can really shake some of the bias that we may have as to what a victim of forced marriage looks like. Again, we are serving individuals of all backgrounds, of all ages, of all identities, and more often than not, they're U.S. citizens, first or second generation, and even have worked with clients where they do not have an immigrant tie whatsoever. And so we are here to promote awareness of this issue, to ensure that survivors of forced marriage or those at risk of forced marriage receive the services across the nation, across professions that they truly deserve. We hope that you see us as a partner if you ever are working with someone who may be at risk, or if you would like to enhance your practices, your policies, and how to better support individuals at risk. We are here and happy to work together. And so before we move ahead, by now, we likely have said the words gender-based violence. We are going to utilize those words or refer to GBV, gender-based violence, in a couple of different areas. And I want to ensure that we are all on the same page. And so when we name gender-based violence, we are talking about acts that directly impact or affect an individual or a group based on their gender. This is rooted in gender inequality, and while we may utilize gender language throughout our presentation, and we know that women and girls experience GBV at disproportionate rates. People at any point in the gender spectrum can be impacted, and that is the same for the issue of forced marriage, which is a form of gender-based violence. And so what is forced marriage? And so to ensure that we are all on the same page, I like to share the definition that grounds Tahirih in the work that we do. When we say a forced marriage, we mean a marriage where one or both people do not or cannot consent to the marriage. And typically this involves elements of force, of fraud, or coercion. At the Tahirih Justice Center, we do not equate a forced marriage with an arranged marriage. An arranged marriage is a process in which families may take the lead, but the ultimate choice to marry remains with the individual. And this next graphic, which was provided to us by Vidya Sri, a survivor who was at Harvard at the time that she worked with Darakshan Raja, who worked at the Urban Institute at the time, they created this continuum, which helps us to better understand how this process can change over time. It is a wonderful image, but it's not perfect because these sort of changes do not always occur in this linear way. That said, the continuum can help us realize how someone may be in a process that they feel is arranged and perhaps find themselves over time in a situation that is forced. And we've heard from clients of all ages that, at one point I did not mind my family or my parents or my community being involved in my marriage process, but they said that I could go to college and I'm still in high school. And now they said the time has come and that I can't wait, right? And so we see those cases where emotionally things can be really jarring when you thought that you had consent or you thought you had choice, but something is now changing, right? And so again, there's a wonderful image, not perfect, but truly can help us to hone in on when choice, when consent is being dismissed, that's where we are seeing things changing. And of course, survivors can name, the process, in their own way. We're utilizing the words forced marriage. Maybe they utilize the words arranged marriage, or to name the, what's their situation. But again, we're looking for consent. And so regardless of the terminology that is being used as service providers, what we're looking for, what we are listening for are those elements of force, of fraud, of coercion, and is there consent throughout the process. When we're discussing consent, it's not just about the person that they may be introduced to, but it's really at all levels of the marriage process. It's even about the idea of marriage altogether, right? Can they freely express their wishes without negative consequences or fear? Do they even want to get married? Do they want to get married to the person that they may be introduced to? And what about the timing, right? Do they want to be married right now? Is there a timeline that's discussed that the person is agreeing to? And if there is a no at all in the process, then we know we do not have the full and free consent at all levels. Casey, I'm going to pass it to you to share a bit more about what lack of consent can look like.
Absolutely. Thank you, Halitz. So, it's really important that we understand consent as sort of a multifaceted decision-making process. So, lack of consent in the cases that we see can be caused by a number of factors alone or taken together. Sometimes a lack of consent is brought about by the fact that someone is simply younger than the legal age to consent. Other times, and I would say most of the time, we see individuals subject to forms of force, fraud, or coercion. And we'll talk a little bit about what those forms of force, fraud, and coercion can look like in the next slide. But here I want to talk a little bit more about what it can look like if someone is subject to incapacity or disability and is therefore unable to consent and forced into marriage anyway. And I can give a couple of examples that help sort of round out this particular issue. When we talk about incapacity, what we mean here is, situations that, clients have shared with me where they were quite young and they were plied with alcohol. And the entire time a marriage ceremony was happening or a trip overseas was happening, they were incapacitated, they were drunk, and they did not know what was going on. They couldn't understand what was being said, and they did not know what they were signing. I have also dealt with situations where an individual came to us as an advocate for someone whose family member had power of attorney over them. And they were working to marry that individual off without their consent, sometimes because the quote unquote, the burden of taking care of that disabled family member became too much, whether that's financially or time-wise or a combination of the above. They were going to use that power of attorney to get that person married, move that person into someone else's house, and quote unquote, make them someone else's problem. And we have worked with disability advocates to try and intervene in some of those cases in the past as well, especially when those individuals really could not articulate well for themselves what was happening, what marriage is, what the expectations of a spouse are. So that's what we mean when we talk about subject to incapacity or disability. So to unpack a little bit the kinds of coercive tactics and sort of contextual factors that we see and that we sort of classify in these cases as force and coercion, and sometimes just fraud in and of itself. So a lot of the folks that we have worked with over the years have shared with us similar things that Dr. Batool saw showing up in her research when she was interviewing survivors. And so, through the lifespan, we're seeing a real normalization of violence in order to get someone to capitulate to something that they don't want, knowing that the threat of violence kind of lies behind any request that you are not comfortable with. Threats to disown, to say, you can make your own decision, you can walk out that door, but you will never speak to your family again. No one from the community will speak to you again, and you will be disowned, disavowed, ostracized. And then where will you be and who will you go to for help? That is a really heavy threat for anyone, especially someone raised, in a very close-knit community for whom religion or culture or other things are very important. Lots of intergenerational components when we talk about these cases. There may be mental health concerns that have never been addressed. When we're talking about someone who's experienced years of emotional and physical abuse, or maybe witnessed that in the home between their parents or other relatives, that will undoubtedly cause trauma, which can lead to things like anxiety, depression, hypervigilance, you name it. But there's so much stigma often around mental health and around seeking help for mental health that often those things go unaddressed for a long time. And that can compound intergenerationally, causing some really unhealthy dynamics within families and across generations. Again, talking about normalized violence, lack of that emotional support and nurturing as someone is growing up can have a real impact on someone's ability to see that what is happening to them might be wrong, to have the confidence to stand up for themselves, to know how to voice their own opinion and to protect themselves from harm, to know that they can expect and should expect to be protected from harm is also something that I know survivors have reflected on with Dr. Batool, that, you know, many grew up not even knowing that that's something that they should expect, that they should be protected by their parents from harm, be it emotional or physical harm. And if we want to sort of build on that theme of historic and related trauma, you know, I think for the most part, those we have served and those that have talked to researchers reflecting on their own experience, is the fact that forced marriage is really just, you know, it's a form of violence in and of itself. When a woman feels that she has had no real choice when it comes to marriage, she has lost a great deal of power and control over her own life. But more often than not, we know forced marriage is just one part of a spectrum of harms that a woman who is forced to marry may face in her lifetime. Likely, a woman forced to marry has experienced abuse and violence prior to the marriage as part of the effort to get her to capitulate. And the moment of marriage itself is a moment of harm and abuse. And while not always, it is fairly common that there will be emotional, physical, psychological, reproductive abuse within that relationship after they are married. And by its very nature, whether or not there is violence present within the marriage, there is a tremendous power imbalance given that one person was forced. What is unique is that forced marriage is often not typically the presenting problem. And so it's often overlooked as part of a survivor's trauma history and therefore not tended to appropriately. Asking the right questions and screening is what we're going to talk about today. And that is what's really needed for a survivor's full trauma history to be tended to appropriately and to serve them holistically. So again, talking about this intersection, it really kind of goes without saying that non-consensual sexual contact and behavior is likely to follow a non-consensual marriage, but it's important to remember that rape and sexual assault can be both a cause and a consequence of forced marriage. So it is a scenario that we have seen more often than I'd like, that individuals have been forced to marry their rapist to cover up the crime and to prevent prosecution of that individual. We could do an entire presentation, of course, and it deserves its own in-depth sort of training, but on female genital mutilation and cutting. But it's important to understand that in communities and cultures where FGMC is happening, it is often very related to the idea of marriageability. And so if you have someone coming forward talking about, you know, being afraid of being forced into marriage, and there's a chance that they could have undergone FGMC, you're going to want to screen for that as well. We want to make sure that when we are seeing one, we are asking about the other. So again, we are tending to, in a non-judgmental way, all of the types of trauma and harm that someone may have experienced in their lifetime. And of course, we do want to touch on human trafficking today. You know, it is not common that the cases we see look like or could be classified legally as human trafficking cases. For the most part, the motivations of these families is not financial and is not necessarily exploitative, though it is very important to be aware of the ways in which elements of forced labor can be present, especially when we start to see these situations sort of shifting more into a servile marriage situation. And so in our observations, in our work, again, we see exploitation and monetary gain, not the main drivers or motivations, though exploitation and financial motivation for family and perpetrators of the forced marriage can happen, sometimes related to the relieving of a debt or, you know, some sort of other arrangement that a family has. Sometimes there is such a lofty exchange of money in terms of dowry or bride price that it could rise to the standard of human trafficking. But again, more often than not, what we're seeing are things that look more like labor trafficking under the guise of marriage than we are seeing things that look like sex trafficking.
Thank you so much, Casey. Apologies for not being on video. My settings are a little changed at the moment, but I like us to move forward for the sake of time, and I'll have my colleague Brianna assist me on getting my camera back. And so I'd like to go over Katie's story and for you all to think about how you would be able to support Katie. And I have some questions for group discussion that I hope we can share via using the chat. And so at 19 years old, Katie was told that she would be traveling to her mother's home country to visit her sick grandmother. Before traveling, her parents encouraged her to go to her primary care physician for a woman's wellness check. Katie thought this was odd as she was feeling fine, not complaining or in pain. Typically, Katie goes to her doctor's visits with her older sister, but during this appointment, her mother went and asked about Katie having a gynecological exam. On her way to the bathroom, while her mother completed intake forms, a nurse asked Katie conversationally whether she was looking forward to her vacation. Katie said, "Not at all." The nurse stated, "Perhaps when you get back, you will be able to enjoy your summer with friends." Katie responded that she did not know when they would be coming back. Katie then asked if it was possible to talk privately about contraceptive injection. She said if she ended up trapped overseas, she didn't want to end up pregnant. And to pause here for a couple of seconds to let folks think about that scenario or read over the slide. And now for some group discussion. My first question, which again, I hope folks can utilize the chat, and Casey and Bree, I hope you can help monitoring that. The first question is, the force in a forced marriage can often be subtle. How does force play out in a situation like the one described? In thinking about Katie's story, how does force play out? And if that's tough to answer, are you spotting perhaps other forms of gender-based violence or potential, maybe given some of the wording that Katie is using?
So I've just added in the chat a question. Yeah, so we have one answer from Danielle who says it doesn't seem consensual. I think that's right. From Lael who says Katie was told she would be traveling, not asked. That's a really good sort of attenuation to that subtle choice of language. Exactly. A 19-year-old not managing the appointment forms, a great sign as well. Thank you, Sandra, for sharing that. Halitz, any reflections on those answers?
And I think those are perfect, especially, thinking about her being 19. I also think thinking about the language that she utilizes, right? Being trapped overseas, not wanting to get pregnant. Again, that doesn't sound like a consensual trip, right? And so I I think those are great. So thank you for those of you who answered. And I see
welcome.
that I'm back on camera. So thank you, Brianna, and those of you who are helping me out here. When it comes to the challenges, what challenges would a medical provider, and when we utilize healthcare providers or medical providers, we really mean at all levels, right? If you work in a medical practice, right? So what challenges would you face when working with someone in this situation? And Casey, I ask for your support when it comes to the chat. Casey, I just asked for you to unmute.
Yeah, so I think we just had one really great observation in response to the first question, which was visiting sick grandma but needing a women's exam doesn't really add up. And I think that's a great observation. And I would love to hear from folks in the medical profession. Long time ago in a previous career, I did a lot of medical advocacy with refugees, and it meant accompanying them to appointments a lot. And what I noticed in almost every clinic is that time could not be more limited. Resources could not be more stressed. And so if you had this interaction with Katie, in what ways would you be challenged to respond and react in that moment? And we can give people maybe just another second or two. All right, there's one. I imagine you would not have enough time alone with her. That would be challenging. Absolutely. It would be imperative to get Katie separated from her mother in the exam room so she could fully express herself. Yes, that's exactly right. And Halitz will talk about a few sort of tools and protocols that we've reflected on with other medical providers in the past that can help with that, to address that issue.
Thank you, Casey. And I think that last comment goes to the third question, which is how would you increase Katie's opportunity for support and help seeking? But I'd love to give folks, another minute to think about their own practice or their own place of work and how you would be able to implement a policy that could support someone like Katie, or if you do have any policies that quickly come to mind that you all have already addressed so that someone in Katie's situation or facing any other form of gender-based violence could receive, help in that moment.
And Halitz, we do have one comment in the chat that says the age remains a major flag and that cultural and family dynamics are challenging.
Thank you. I really appreciate that last comment. And before we go into our 5-minute break, I think that comment leads us to a piece of a narrative that that clients have shared with us in the past, especially when situations like culture or family dynamics come to play. And we hope that at the help when someone is seeking help, when someone is seeking services, that culture or their community or any sort of scene differences are not barriers to the help seeking process, right? If someone is asking for help, regardless of what background they're on or whatever we may not know about their culture or community, that we through this training emphasize the importance of being non-judgmental, which we'll talk about later on, and non-judgmental at all levels, about their family, about community, about the person themselves, and remembering that they are members of their community, they are members of their family, and they also have a right to stand up to practices, to behaviors that they do not see are safe or healthy or just for themselves, right? And so I really appreciate that comment. And though that's a whole other training in itself, I do think it's important to name the folks, autonomy, regardless of, where they come from. And so I would like to give everyone a quick 5-minute break. And if someone could help me with what exactly 5 minutes means. I don't have a clock in front of me. What time would that be, Casey?
That it is 2:44, so we're gonna come back 5 minutes from now. It's gonna be 2:49.
All right, so the 49-minute mark, wherever you may be, we'll talk in just a few minutes. Thank you all. Thank you so much, everyone. We hope you were able to take a nice little break. We understand that these topics are um, a lot to go over, for lack of better words, even though we are focused on supports and how to maximize help seeking. They are still tough topics. So I truly hope that folks were able to take a little bit of a mental break. Now we're going to transition a bit to discuss child marriage. And this is because as we began our program, we learned that those who are marrying under the lawful under 18 years of age, where folks typically have access to more rights, they were incredibly difficult and continue to be very difficult to help and work with. And so our team at the Forced Marriage Initiative has been working on the issue of child marriage in the United States. And similarly to how we do not equate a forced marriage with an arranged marriage in every instance, we do not equate child marriage with forced marriage. We can see a world where there could be two very mature, in love 17-year-olds who truly want to marry. But what we know from the data is that those love stories that people think are not necessarily what is happening. What the data shows us is that they are some concerning factors, and across the board, even when folks are not being forced to marry, girls do unfortunately, just the outcomes are not the best. And so what the data shows us about the majority of child marriages in the United States were that the vast majority of those cases, and we've been able to research and uncover about 300,000 cases of minors being married. And again, though we cannot say that all of those cases were forced, what is concerning is that most of those cases involved girls marrying adult men. Often they were decades and decades older. The marriage ages were lower than the age of consent, meaning in some states, girls were marrying before they lawfully could actually consent. And there were parental consent exceptions to marriage, which in our work, when we know that the majority of those we serve are being coerced by parents, we certainly see those parental exceptions as a way to enable parental coercion. And so this is an entire training in itself when we have lots of resources on this issue. I will share some good news that since we launched the first campaign on this issue in 2016, the movement has grown. The movement to end child marriage, I should say, has grown. Many states have strengthened their laws. We continue to advocate for change and are actively involved in several campaigns. But all of that is to say, again, US specific research does show that women who marry as girls, they do not do well overall. Child marriage is just bad public policy. Whatever a girl's starting point, child marriage truly stacks the odds against her, and the risk of increasing her instability and insecurity over time are just too great. There's a greater vulnerability to violence, there's higher dropout rates, higher likelihood of poverty, and as I'll discuss on the next slide, increased medical and mental health concerns. Women who marry before age 19 have a 23% greater risk of developing serious health conditions, including diabetes, cancer, heart attack, and stroke or stroke. Teen girls who marry tend to have more children and earlier and more closely spaced. They're more likely to have their first child before age 18, 40% more likely to have a second child within 24 months of the first, and nearly 3 times more likely to have at least 5 children. There's unintended, pregnancy, maternal death during childbirth. Often when we're working with individuals who have, been forced to marry, young, they share that, they did not have access to medical providers, right? Their spouse or their parents or both controlled when they sought out medical care, and often that was not a priority either. Mental health impacts are also great, and in 2015, the World Health Organization reported that they found suicide to be a leading cause of death for older adolescent girls worldwide, and forced marriage was specifically identified as a factor that increased this risk. This fact continues to be the case for the cases that I have worked on. I unfortunately cannot say that I have worked with someone who has not mentioned suicide or suicidal ideations as the way that they see as an out to what is going to happen. And so, again, there's incredible mental impacts. And my colleague Casey will share a bit more about just these mental health impacts across the lifespan.
Yeah, thank you, Halitz. I think that is always a pretty sobering reality to talk about when it comes to these cases. And I know that sort of cursory mental health screening is often happening in lots of healthcare settings. If you're a mental health care provider, this is obviously more than cursory. And I think for us and the clients that we have served, whether they're 17, 27, or 47, they need to know that it will be safe to talk about this kind of abuse in the therapeutic setting without being judged, without getting, bug eyes, like, oh my God, that's the craziest thing I've ever heard, but in a way that will just feel like they're being heard, that they're being empowered, that they're not alone, they're not the only person this has ever happened to, and critically, that they are not to blame. One of the terms that Dr. Batool has used as a result of this research is this idea of betrayal trauma, that the people who were supposed to love and protect and nurture you the most were actually the ones who put you in harm's way intentionally, whether or not they thought they were doing, quote unquote, what was best for you at the time. Those who were supposed to protect you didn't, and in fact harmed you intentionally. And that stays with someone over the lifespan. And I think another element that I want to uplift for this audience is the element of self-blame that exists for all survivors. How could I have let this happen to myself? Why didn't I fight back or find a way out? And I will say that for those who faced forced marriage in adulthood, this can be even more of a heavy psychological burden to bear, because there's this sense that, well, children forced into marriage are extra vulnerable. Of course, they couldn't help themselves. They were children. But I was an adult. What was I thinking? How come I couldn't get myself out of this? And that takes a really long time to unpack, that mentality of blaming yourself for abuse, blaming yourself for how long it may have taken you to get out of that relationship, and the lack of self-confidence, the depression, the anxiety, again, the hypervigilance around what are other people thinking, what are other people feeling, how do I stay safe? really follows people throughout the lifespan. It can impact their educational attainment, their career trajectory, and it's something that, you know, is important to connect the dots on, especially if you're in the mental health setting with survivors. And speaking of that, one thing we also wanted to uplift from Dr. Batool's research are the reasons why survivors often discontinue services with mental health providers. And this is something I know Halitz and Brianna have seen in their casework. It is absolutely something that I have seen in mine, that even the most well-intentioned mental health care providers who may be expert in, you know, treating survivors of torture or survivors of gender-based violence, they are struggling to build rapport with forced marriage survivors. They are struggling not to show their own biases. They are struggling not to show up with white supremacist habits. And all of these things, whether they are subtle or overt, make it really hard for someone to feel confident that investing that time and investing that emotional intimacy with a stranger is going to pay off in the end. You know, what am I going to get out of this if every time I'm in this office I feel judged, I feel like a freak, I feel like we're not talking about anything that's really going to help me move past how I'm feeling and into a place of confidence and moving forward with my life, and the sense that I'm not being listened to about the impacts of medication. A lot of times, you know, the survivors we're working with really struggle to stand up for themselves, really struggle to say what's really happening inside of their bodies. And so if they're saying, even in the most subtle way, they are not liking the way that they're feeling inside of their body and inside of their mind because of some of the prescriptions that they're being put on, it's really important to pay close attention to that, because if they're saying something, there's probably a lot more there. And that needs to be addressed, because again, they will self-manage in ways that may or may not be helpful to them in the long run. And better that we are listening to them and helping them through this process together in the best possible way than dismissing, diminishing, not taking the cues, and having them discontinue services and self-manage medication on their own.
Casey, thank you so much. And just to stay here a little more, this point on feeling judged and shamed for being a young mother stood out to me, especially working with survivors who, you know, were forced to marry as children and in adulthood attempt to seek out mental health services. Well, both as you know, when they're younger or also in adulthood, and not feeling comfortable in even disclosing or even being asked how the nature of that you know, that pregnancy even came to be, right? And that's something that I think see a lot in our work, when folks are not being asked about the nature of relationships, and there's this assumption, right? Oh, you were just you know, a bad youth, right? A runaway, and you got yourself, you know, pregnant, and not necessarily asking the right questions for folks to be able to actually share what was happening to them.
And if I can give one other example, because I think we're doing pretty good on time, of like something you might observe in a clinic and then only later reflect on, that might have not been right. That was a dynamic I might have wanted to put my finger on a little bit more. I've been working with a survivor recently who was married at the age of 15 to a man who already had a child who was 4 years younger than her. And she would sometimes be forced to take him to his medical appointments as his guardian. She was 4 years older than this young kid. They were basically brother and sister, and yet she was his stepmother. And so in those moments, what I wouldn't give for a medical provider in that moment to have paused and asked some questions about that dynamic, both for the young boy who is clearly in a home where he's witnessing abuse, and for the survivor who is a 15-year-old married to a 37-year-old man who's having her take his child to the doctor.
Thank you, Casey. That's a lot for folks to think about. And as we transition to I think the question of of the webinar, how do you ask if someone is facing a forced marriage? It's a good segue into pausing, right? Pausing to for everyone, even right now, to think about how can you maximize support if you were to encounter the situation that Casey mentioned, if you were to encounter the situation that was shared when we discussed Katie's story, right? If this was at your practice or the place where you work, what protocols do you have in place already when someone discloses abuse? Are those protocols that would actually maximize support? Or now, as you're thinking about what we've discussed, do they need to be enhanced so that folks can truly have a place to share what is happening to them if they choose, or at least for you to be able to actually offer support? I think often we are focused on, folks disclosing, but that's not necessarily the goal. The goal is, if you suspect, if you're able to spot these warning signs, or the warning signs that we have talked about, or in thinking of the narratives that have been shared, how can you actually maximize support and for that person to have an opportunity to seek out help, right? And so we've named some of these warning signs throughout the presentation. This is a comprehensive list if folks want to print or have at their place of work, or utilize this list as a way to create or enhance your tools. But again, just to highlight that the fear of upcoming holidays is something that comes up in our work, that references a bit of Katie's story, right? Not being sure if they're going to return from that holiday. Perhaps that won't come up for you, but maybe you're working with someone who has a history of running away, or their parent is labeling them or their community member as a troublemaker, right? Or their case manager, right? You're getting information from that case manager who perhaps has not had a lot of opportunity to build rapport, and they just know what the parents are telling them, right? And so when you're noticing, multiple warning signs, I would encourage you to ask more questions, and to just be prepared for those moments. And so we believe that providers should talk with all patients about elements of healthy and unhealthy relationships, right? That sharing about the health effects of violence, health promotion strategies and resources across the board will be helpful to ensure folks at risk have the information that they need. One of the approaches that we have learned and that we know to be successful is from our partners at Futures Without Violence. And this is the CUES evidence-based intervention, which is also a trauma-informed intervention to address domestic violence in health settings. But we think that it's also helpful really in addressing multiple forms of gender-based violence. And so we've named already confidentiality, or we've named it as speaking to patients privately. And I think we can't stress this enough, that in order to create a safe space for individuals to discuss their experiences and to be able to disclose sensitive information, they need an opportunity to be able to speak alone. And one of the best ways to achieve this is by establishing a policy within your clinic or the healthcare setting where you work at, or you routinely see patients, where you interview them alone. And whether that means alone but with a colleague, what we mean is alone from the person or people that they may have come to the practice with. This also includes children, because children may be tools to report information back to abusive family members. And so we have to be careful who we're bringing into those appointments, especially if we're trying to maximize the opportunities for folks to be able to have that private, safe space. Also, in having this as a standard practice, it helps to alleviate some of those suspicions that the patient or their family member might feel, and any unintentional targeting of particular individuals or particular communities, right? So it is a practice that is across the board. You always, want to have some moments of alone time with the patient, again, at least for part of the visit, and utilize that time also to disclose your limits when it comes to confidentiality before you're diving into any sort of conversations on gender-based violence or maybe other forms of intimate partner violence that you may be spotting. If you're able to make this a standard practice, we truly believe that you will maximize opportunities for support without signaling to someone, without singling out someone potentially at risk, and singling them out to, again, potential perpetrators who may be with them. At our colleagues at Futures Without Violence, they have created some wonderful safety cards for universal education. And these are cards that, if safe, include information on healthy and unhealthy relationships. Our team has also created some safety cards that we are able to, send you all to print. I know Futures has a lot of free materials and free safety cards in multiple languages that include healthy and unhealthy, relationship advice and guidance. And this is a wonderful way to already have those tools saved and be able to share, with, your patients or individuals at risk. A wonderful tool when it comes to empowering the person who may be at risk is, maybe they're not disclosing and disclosing is not the goal, but perhaps you can give them a tool because you have spotted some warning signs, whatever safe way that is, if that is a safety card, if that is a pamphlet, or maybe it's writing down a safe phone number and letting them know, like this could be for you. And if not for you, perhaps you can share this with somebody else who may benefit from this information, right? Again, that person may not disclose, but has the information and knows that it's not just for them. They can certainly share if they know someone who is at risk. And last in the cues intervention, which I absolutely love, is the reminder that, the S stands for support. It is not about disclosure. That is not the goal. Disclosure could happen, right? And you want to discuss a patient-centered care plan to encourage, harm reduction. You want to be able to make warm referrals. What does that look like at the place where you work or your practice, right? Is there a phone in every, meeting room, right? Is there access to that? Do you know who is your local domestic violence or sexual assault violence partner, right? And can you document the disclosure or your potential warning signs that you spotted for the follow-up visit, right? And that is incredibly important. Often we're working with folks who, hey, I think something is happening, but maybe they're not going to be on during that next appointment, right? And so how can your colleagues support in asking more questions or offering more opportunities for that person, right? So they're not necessarily starting, from scratch, and that they know that perhaps there's more to look into when it comes to that person that you are seeing for that day. When we discuss our role, and we mean our role as service providers across, the movement to end gender-based violence, we always want to encourage folks to start a conversation that is based on trust and respect, regardless of the age of the person who you are meeting with. This is just incredibly important, and to ground yourself in a non-judgmental point of view, right? A non-judgmental point of view about them, about their family, about their culture or community. You really need to check, your bias and be knowledgeable about resources and provide information, be able to make referrals and those connections. This is incredibly important. We do not know when that person is going to be able to ask for help again, right? We do not know if they're going to encounter a provider who's going to be able to actually spot some of these warning signs or red flags. And so offering folks resources in the moment, an opportunity to self-help, perhaps by, calling from the office while, the appointment is going on, and you step away and you give them an opportunity to utilize neutralize the phone potentially, or just letting them know that you believe you're noticing something that may not be right, and sharing more about healthy and unhealthy relationships can truly be life-changing. You may be the only person that has ever shared with them that they actually have, a right to, say no to a marriage or to a partner they do not want, that they have a right to leave a marriage that they do not want. You don't have to get into great detail. You don't have to know everything about, folks' background, but being able to give them supportive information is just incredibly needed as they navigate what the help seeking process looks like. In our work, we have learned and believe that no religion sanctions forced marriage, and intercourse is not an obligation, and rape and sexual assault can occur within a marriage. And you may be surprised to know that often myself or my colleagues have been the first people to tell some of our clients that rape and sexual assault can occur within a marriage. And this has been, incredibly powerful to them because, again, they just have never, many of them, I should say, have never been told this information about what their rights are, and that they are able to seek help and deserve to be in healthy relationships and not in, an abusive households. And so getting back to that question of how do you ask, we've listed some ways that you can ask. Again, asking is key. It's not just asking about, are you being forced to marry? Likely that answer is going to be no, but what sort of open-ended questions can you ask that allow for folks to share a bit more about what is going on? Again, if it is appropriate, because disclosure, again, is not key in healthcare settings. Is really about offering that support. But if asking is needed and helpful, we want you to ask in ways that, again, are non-judgmental, that are supportive, and that help you better understand what is happening. Do they have a choice in deciding who they will marry? How has marriage taken place in their family? How do they feel about that for themselves? If they mention a marriage partner, like how is that person, being selected, or who is involved, right? How did their engagement come to be, or when was the last time they, saw their partner? Are they being pressured to marry someone who they do not want to marry, or pressure to marry someone they are unsure about? For many individuals, sharing about family business, is not something that, is common. They've been told these are private family matters. And so the way that we ask truly determines how, they will respond. And, in their response, again, how we follow up is also incredibly important so that they can continue to feel not judged, and that you are truly wanting to offer opportunities for support. Some additional considerations that I like to name, like, again, going into, confidentiality and naming mandatory reporting, mandates or structures from the very beginning. As I mentioned, with the CUE's evidence-based intervention method, disclosure is not the key. It's about support. And so if you keep that in mind, if you're working with someone and you think that this may trigger some reporting mandates, I encourage you to pause and think about how can you still offer them support for what you have, noticed, the warning signs, the red flags that have been present, and still give them a way to be able to access help, whether that's our line, a teen helpline, you name it, before getting into deeper questions that may lead to disclosure, that could lead to reporting. It's also incredibly important that you explain what that actually means, because folks may not understand, mandatory reporting. What does that mean? If you make this phone call, what can actually happen, right? Give them an opportunity to maybe pause sharing if they don't want to, and you still, can you still give them a phone number to self-help? Can you give them our contact information? Can you give them, a local organizations line for additional support? I think the answer is yes. I don't think that will interfere with your any sort of reporting mandates. We can certainly provide crisis lines and information and still fall within our mandates. Something that we see often, especially when we're providing services to organizations or colleagues who are working with refugee populations, is the use of community members or use of family members as interpreters, which we understand it can be tough to identify interpretation, but this has certainly been a barrier for folks in disclosing, right? I'm not going to disclose that the person who is translating is forcing me to marry, right? I'm not going to disclose that there's abuse happening at home if I know that, my little brother who is translating is going to report everything about my appointment back to, to my parents. And so that is something to keep in mind, and how can we utilize interpretation services, language lines, or even if someone is working already with a social services agency, can we utilize their interpretation services if your practice is not able to offer them that accommodation? I always say do not send individuals away or return them to family members against their wishes. And do not approach family members or community members, if the person has not specifically asked you to do so. This is a habit that we've seen be incredibly dangerous. Folks wanting to act as mediator, this sort of belief that, oh, well, if we just tell them that this is wrong, then they'll stop. And that goes back into, these thoughts that forced marriage doesn't occur in the US and that this is an imported issue. And that is not the reality, right? We have this issue right here in the United States. We may not call it forced marriage. We may call it something else, like, a shotgun wedding, or, we may hear of terms like, oh, well, if you get pregnant, you have to marry, but we don't see that as forced marriage, when in reality, that's what it is, right? And so it is incredibly important not to place yourself in an individual's life if they haven't asked you to, right? Like, how can you just provide them with support? And I shouldn't have said just, how can you provide them with support? Because that is truly key. And so I'm listing on this next slide some clinical recommendations that Dr. Batool shared. I'm not going into detail on these clinical recommendations for mental health providers, but we did link the research and the presentation that Dr. Batool did for our organization at the end of this presentation. And I believe my colleague has also linked it in the chat for you all to access for further and deeper discussion on her research. As we, wrap up and we have a couple of more slides, I think it goes without saying that taking a survivor-centered approach is key in working with individuals at risk of forced marriage, individuals at risk of any form of gender-based violence. As we named earlier in the presentation, forced marriage is a form of violence in its own right, but often it is connected to other forms of abuse. And so if you're working with someone who is, showing signs of forced marriage, they likely have experienced other forms of violence and or will be experiencing other forms of violence. And so the way that you approach them is key. They are thinking about potentially leaving the only home they have ever known. They are potentially lacking in life experiences and resources, could be fearing for siblings, for loved ones, for pets. And the reality is that these are very complicated situations, complicated feelings towards family and loved ones and their own identity, right? I love these individuals and they're causing me harm. I love my family, but I don't think what they want for me is right. But what does that mean now? And how do I get help and still keep a tie to my family? And is that even possible? Right? So they're grappling with a lot of thoughts about themselves and what just the help seeking process looks like. We often say to be ready for second thoughts and for folks to backtrack on decisions. Perhaps you come up with a plan with someone and then they say, nope, I'm okay. I don't want to make that phone call now. That's okay. We're not going to pressure them. The goal, again, is to still be a supportive person, to offer them the appropriate resources and to document your concerns for follow-up, right? Are there ways that you can enhance that follow-up visit if you're not there so that the next provider, your colleague, can continue to offer support and see if they also spot some additional warning signs. And so I'm going to ask my colleague, Bree, to launch the poll again. And Casey, if you can let me know if anything has changed, that would be wonderful.
Absolutely. So we'll just give people a minute.
I'm going to read the poll for the Spanish language audio, and the poll again states, have you ever worked with a patient who was facing forced marriage dynamics? The options are unsure, no, or yes.
Okay, we'll give one more handful of seconds for folks to answer. And I think the good news as ever with these polls towards the end of a training like this is that the amount of people saying unsure is much lower than it was at the beginning of the training, which is fantastic. And I think, Bree, you can probably go ahead and close the poll if you want to. And what's interesting as we're unpacking some of assumptions or other things or true warning signs, etc., we have more people now saying no than yes. The number of people saying yes has stayed about static, and two more people actually are now saying no that they haven't, which for me is actually really heartening in that people are maybe reflecting on things that they might have thought could have been forced marriage situations, and now after learning a little bit more thinking maybe that was something else, or maybe that was just a bias or an assumption that I had and it's not actually forced marriage. So I'm really grateful for the data and for the honesty and for the learning that we're seeing reflected in the poll results. So thank you, Bree, for opening that up for us. And I think we can go ahead and close ourselves out. And with gratitude, this will be the last time I speak, so just want to say thank you to everyone who was here today, and thank you, Halitz, for all of your incredible hard work putting this together and presenting, and all the staff that have helped make it possible as well.
Thank you so much, Casey. Before we close out, I do want to make sure that folks have an opportunity to utilize the chat to ask any questions or share any comments. Bree, I would ask you to read those if there are any.
We don't have anything just yet.
And nothing in the chat, just gratitude.
Well, thank you everyone for being here. I will go back one slide to share our contact information. The email is fmi@tahirih.org. That email goes just to our team, FMI, the Forced Marriage Initiative. The phone number to contact us is 571-282-6199, and this is a direct line to our team. If you would like some additional technical assistance, if you would like some additional support or guidance, if you would like us to connect you to Dr. Batool or colleagues over Futures Without Violence, and or share any sort of posters or tip sheets, you name it, please feel free to contact us. I believe my colleague colleague Brianna has shared in the chat the tip sheet that we created to go hand in hand with this webinar, which was informed by wonderful volunteers through many different levels in the of medical providers. And so we have that tip sheet, which we hope is helpful to you all. And another thank you to everyone who supported our webinar, to all of our interpreters, and again, to the U.S. Department of Health and Human Services, Administration for Children and Families, Office of Trafficking in Persons, who have funded this webinar. Thank you, everyone. Bye-bye.